Hello and welcome to Module 10, Atypical Wounds. Our objectives for this module are to discuss the pathophysiology of atypical wounds, define the components of a complete patient assessment, detail the treatment protocol for atypical wounds, and introduce types of atypical wounds. Atypical wound pathophysiology. Wounds that cannot be defined under one of the other primary non-healing wound categories are considered atypical wounds. Atypical wound etiologies represent a broad spectrum of conditions or diseases caused by inflammation, infection, malignancy, chronic illness, or genetic disorders. Atypical wound etiologies should be suspected if a wound has abnormal presentation or location and does not progress following evidence-based treatment protocols. The prevalence of atypical wounds has been estimated to be as high as 10%. Consider obtaining a punch biopsy if the diagnosis is uncertain. Associated comorbidities. Atypical wounds are often linked to other comorbid conditions. If the patient's medical history is positive for inflammatory bowel disease, rheumatoid arthritis, or hematologic malignancies, consider pyoderma gangrenosum in your differential diagnosis. Patient has a history of chronic kidney disease, uremic disease, or is on dialysis, consider calciphylaxis in your differential diagnosis. Patients with hypertension, obesity, and type 2 diabetes may suffer with wounds caused by hidradenitis suppurativa. Patients having rheumatoid arthritis or other connective tissue diseases are more prone to develop wounds from vasculitis. Patients taking vitamin K antagonist medications can also develop calciphylaxis, Coumadin-induced skin necrosis. Older patients, immunosuppressed patients, and wounds that have been open for a prolonged duration should be considered for malignant causes, and recurrent lesions in the axilla, under the female breast, and in the anogenital region or groin should also have hidradenitis suppurativa ruled out in the differential diagnosis. Atypical wound examples. Pyoderma gangrenosum, also referred to as PG, is an uncommon ulcerative disorder of uncertain etiology. Patients present with a rapidly enlarging painful ulcer, typically classified as a neutrophilic dermatitis or dermatosis, characterized by full thickness ulcers with a blue or violaceous undermining border that display pathargy. More common in patients over the age of 50, and the general incidence is estimated to be 3 per 10 per million per year. Histology shows deep suppurative folliculitis, and the hallmark of pyoderma gangrenosum on histology or after taking a biopsy is a dense neutrophilic infiltrate. 40% of these cases will also show leukocytoclastic vasculitis, and pyoderma gangrenosum with necrotizing granulomatous inflammation has also been routinely seen. Treatments for pyoderma gangrenosum include topical and local treatments with topical steroids, interlesional steroid injections, and associated proper wound care. Surgical debridement should be avoided in patients with suspected pyoderma gangrenosum. Surgical debridement of these types of wounds actually make the ulcer worse. Systemic treatments can include oral anti-inflammatory antibiotics, oral prednisone or IV steroids, and other active biologic agents. Vasculitis is an autoimmune disorder affecting vessels of any size and any type. Usually the etiology is multifactorial. Potential influences can include ethnicity, genetics, gender, and environmental factors such as ultraviolet light, infection, toxins, drug exposure, smoking, and surgery. The skin is the most common organ for vasculitis to occur. The clinical manifestations of vasculitis depend on three core criteria: the location of the vessel, the type of the vessel, and the size of the affected vessel. Common findings on histology, on biopsy, would be a perivascular infiltrate of inflammatory cells and fibrinide necrosis of the vessel walls. Treatment for vasculitis depends on the disease type, the affected organ, and the severity of the illness, but a multidisciplinary approach is indicated and may include rheumatology, pulmonology, cardiology, vascular surgery, podiatry, wound care, dermatology, endocrinology, and/or neurology. Malignant wounds. The presentation of malignant wounds primarily depends on the rate of growth and the level of infiltration of the skin. Initially, the development of a non-tender nodule can occur. As this nodule enlarges, it may begin to interfere with the function of the skin, and in time, cause lack of skin perfusion, edema, skin breakdown, and necrosis. Wounds can sometimes resemble a crater with a raised border, or in proliferative wounds, they will appear as fungating or raised up like a cauliflower. Some malignant wounds can demonstrate both patterns of growth. Malignant wound treatment. Wide surgical excision is the best solution to malignant wounds. If left unmanaged, these tumors may continue to grow and penetrate into the deeper structures. It is not uncommon for malignant wounds to cause pain, exhibit excess exudate, have a malodor, and/or bleed profusely. These wounds rarely heal and often deteriorate even despite adequate wound care. Calciphylaxis. This is a rare but highly morbid pathologic syndrome of vascular calcifications and tissue necrosis. Clinically, patients may present with areas of tissue necrosis and/or non-healing wounds. Although the disease has been documented since 1898, the condition is still poorly understood and continues to be a treatment challenge to clinicians. A definitive diagnosis of calciphylaxis requires a tissue biopsy. Histologic findings typically consist of calcifications of the small and medium arterioles, considerable hyperplasia, fibrosis, inflammatory infiltrates, subcutaneous calcium deposits, fat necrosis, and vascular microthrombi. Additional histology are often seen that include tissue calcification and ischemic epidermolysis. Calciphylaxis is predominantly seen in patients with end-stage renal disease on chronic dialysis. 1 to 4% of the population with end-stage renal disease may show signs of calciphylaxis. The overall prognosis is bleak. Complications such as amputation, infection, or death occur in 60 to 80% of patients affected with calciphylaxis. And this disease has a 1-year mortality rate, which is high at anywhere from 45 to 80%. Advanced wound care is crucial to prevent infection in these wounds. Additionally, sodium thiosulfate IV has been reported to have some success. Treatment considerations. Diagnostic testing should include ABI and TBI if the wound is on the lower extremity, fluorescence imaging, oxygen assessment imaging if available, hemoglobin A1C in patients with diabetes, culture if clinical signs and symptoms of infection are present. Treatment considerations are often based on etiologies. Inflammatory ulcers such as PG and vasculitis should be treated with non-adherent dressings, hydrogels, topical anesthetic creams, and remember to avoid sharp debridement in cases of PG. Systemic therapies include corticosteroids, immunosuppressants, biologic therapies, and pain management. In cases of vasculopathies, local therapies include non-adherent dressings, autolytic debridement, absorptive dressings, and compression. Systemic therapies with anticoagulants and antiplatelet medications are helpful. Neoplastic ulcers or malignancies should be treated with non-adherent dressings, absorptive dressings, topical anesthetic creams, odor-absorbing dressings, and systemic therapies should include surgical excision and/or radiation. In hematologic ulcers, non-adherent dressings, autolytic debridement, and absorptive dressings should be considered. Systemic therapies such as hydroxyurea or IV sodium thiosulfate in the presence of calciphylaxis have been successful. Infectious ulcers should be treated with silver-impregnated dressings or antimicrobial dressings that absorb exudate, and treat these wounds with antibiotics as indicated. General measures: reassess the patient weekly. Has there been any change in their medical history, medications, physical exam, and nutritional status? What does the wound trajectory look like? Make the treatment modifications based on this information. Wounds not moving into a healing trajectory after 3 months of appropriate treatment should be biopsies. If the wound surface area has not reduced by 40% in the first 4 weeks of care, advanced therapy is indicated. Consider prescribing topical oxygen therapy utilizing NATROX O2. The patient continues to return weekly for evaluation. In summary, atypical wounds like these are rare and not well understood. Wound progression is unpredictable. Knowledge of pathogenesis is limited, and treatment is not standardized. Ulcers are often refractory to typical wound care treatments. Therefore, in atypical wounds, aggressive therapies with the use of systemic treatments may be needed. Here are additional references. And this completes Module 10. To complete the test, please click on the red test icon at the bottom of your screen with the clipboard and pencil on it to receive your certificate of completion for this module. Thank you.